Thank you. Thank you so much, sir, for having me here. I do have a presentation, so I'll do it a little differently. I'll show some use cases and innovations that we have been building in the space of AI for healthcare. But before I do that, first of all, thank you, the organizers and the dignitaries on the dais for giving me the opportunity for this discussion. So my background is in medicine. I did an MBBS, and then I decided to move away from clinical medicine into research, did a PhD in computational biology. My interest was in computation and essentially mathematical approaches to changing clinical practice. So my PhD was focused on building machine learning models. That's when I got acquainted with AI, started building things. And in that process, worked with AIMS for different problems like asthma, pediatric asthma, and in the space of ICUs. So, but why I'm telling you this, I think my talk is going to actually just extend on what has been said before. The stage has been set, all the challenges have been pointed, and I probably will be able to convince you that it is doable in our ecosystem in India. We can actually build our AI systems. We can push the frontiers. So my job, for example, in our research lab at IIIT-Delhi is to push the frontiers of AI, not just use AI, but to build AI that can be then safely transitioned into clinical use. And today I'll be basically talking about AI for infectious disease preparedness. I know that this is not something that anybody needs to be introduced about, right? Because with the COVID-19 pandemic, we all know about how important it is to be prepared for these unprecedented challenges. Next slide, please. I come from IIIT-Delhi. We are about 14 years old now, and I work in the Department of Computational Biology. I also lead the Center of Excellence in Healthcare, where our goal is to actually build AI and digital health tools for healthcare. Next slide, please. So I think some of these terms came up. The center is actually, our mission is focused on building affordable, accessible, and accountable care for all, and transitioning it into practice through research development, education, and entrepreneurship. Very pleased to have Mr. Naresh Priyadarshi here, who's a very good friend and colleague. And essentially, we are working together to build together these three streams of building research outcomes, teaching students, for example, people like me who actually come from a different background. How do we skill them? There are no AI practitioners within clinical training courses these days, right? So how can we build such workforce? And finally, how can we actually deploy and scale up these solutions through entrepreneurship? That's our focus in the Center of Excellence for Healthcare. Next slide, please. So in the pandemic response, we realized that we need to solve three gaps. These gaps have already been addressed, at least pointed out. The first is the data gap, right? We talked about consortium. And the data gap says that we don't have platforms for exchange of data. For example, if AIMS wants to exchange COVID data with LNJP or with Max Hospital, how do we do that? Interoperability is one way, but really does it work only at the level of technology, or are there frameworks needed that go beyond technology, right? Even if we are able to exchange, thank you. Even if we are able to exchange data, there's a knowledge gap, right? Who is using these data? Are the data scientists having the information about healthcare? Are they equipped with the understanding of clinical medicine to really build that, right? Policy gap. If we build that knowledge, does it change anything? With that knowledge, are we able to change anything the way clinical medicine or public health is practiced? So when COVID started, there was basically a huge effort towards solving these three gaps. And from the Principal Scientific Advisor's Office, there was a direct interest expressed in creating a science and technology cluster for Delhi. And we are leading the AI/ML for healthcare vertical in the Delhi Science and Technology Cluster, which is basically the cluster of institutions like IIIT-Delhi, IIT-Delhi, AIMS New Delhi, Ashoka University, JNU, and many more, to create solutions that can actually solve the societal problems. And our goal was to actually build AI/ML by pushing these frontiers and transition and then basically deploy them for COVID-19. So I'll be talking about some of these challenges. Next slide, please. So we built something called the Integrated Federated Health Platform. It's a mouthful. We might change the name, but that was a motivation, that how do we create an integrated platform where institutions can come together, pool their data sets, as the previous speaker said, in a safe manner, right? And then basically there can be models that can be deposited here, a safe sandbox where we can have these models and data sets together. Next slide, please. And this platform is available, open, and we are proud to say that we not just published more than 10 papers in the last 2 years, all in international peer-reviewed journals on COVID-19, but we also created AI-enabled applications that we deployed on our platform. One of the applications that I'll be talking about is called Strain Flow, and I'll talk more about that in some detail. But you also have other applications like Evidence Flow, how to use AI for mining evidence for diseases which are not, for which we don't know anything, right? And then there's a solution that we also deployed called Vaxim, where we used the same kind of AI which is used to train computers to play Mario games better than humans, or to train them to play chess better than humans, to actually do resource allocation better than humans in COVID-19. And I'll briefly talk about those. Next slide, please. Also, we created something called COVID-19 Data Commons Toolkit. Mr. Naresh Priyadarshi talked about having such kind of data sources which startups can leverage. So what we did, we said that we think that there is very little data, but actually if you go out, these days there's something called FAIR data principles: findable, accessible, interoperable, and reusable. These FAIR data policies ask every research study to deposit their research data. There are more than 10,000 data sets on COVID-19 deposited in FAIR repositories in the last 2 years. How many of them have actually been used to combine these different data sets together to build some understanding, knowledge, and to basically build interventions? So we created an AI-enabled data commons toolkit. We now call it the COVID-19 AI Stack. We have not yet integrated into the ABDM health stack, but that's what our vision is. So more than welcome to answer more queries on these later. How did we build, or what do we plan to do with this? Next slide, please. But one of the solutions in this stack is what we call Strain Flow. Now, Strain Flow was our approach to push the frontiers in tackling strain emergence and knowing when will the next surges come, not looking at models that look at case series, but looking at genomic surveillance. Next slide. We basically said that genomic sequences, the virus genome, right? Virus has a DNA sequence, and the DNA sequence changes. Whenever it changes, we have a new strain. And that strain may be more infective, it may be more lethal, it may cause more deaths, and so on. So we asked the question, can the same kind of models that predict what word am I going to type next in my Google email or in my Google search, which are called large language models, can be used to read the sequence of the virus genome itself, and then to start making predictions on what may happen next. That was the core idea. Here on the slide, you see that how our language models were built for more than 3 million sequences, and they captured the changes in how the strains emerged. The bottom right slide shows how 7 different countries, including India, were basically looking different at different time points in our models. Next slide, please. Then we asked the question, it's good that these models capture what biology says without the need for an expert, but can we now use these models to predict new surges? And that's what you see here. I think, so on the right hand side of your screen, you see that there's 2 lines, the red line and the gray line. The red line is a line which our model is actually picking as a signal from the genomic strains, and the gray line is cases in those countries. We have 7 different countries. And what you see is that the red line changes in the same pattern as the gray line, but 2 months ahead of time. What is happening here? As mutations start happening, the virus actually starts First, the virus explores the mutation, and then it exploits a certain set of mutations. When it starts exploiting a set of mutations, that's when a strain gets established, becomes dominant, and then the cases surge. And that's exactly what our models were capturing across all these different countries. The same pattern was observed, that the entropy, which is a measure of noisiness of the, let's say, of the latent dimensions of the model, was able to actually capture 2 months ahead of time how cases were going to change. Next slide, please. This was done for all 4 waves in India, and our models were correct, prospectively validated. We sent our findings, so we shared our findings at all time points, every 2 months intervals with the PSA's office, with the INSA-CoG cluster, and we believe these were acted upon. But as you can see that all these different countries had the same signal. On the top right, you can also see that blue line going up 2 months before the red line went up. So the strain flow models and statistically significant machine learning shows that how important these are. Next slide, please. So we created a dashboard. We wanted these findings to be available to the policymaker. So we created an open dashboard where you can go and look at our models, explore. Now we are actually changing the back end of our models with even more advanced models, which are the state-of-the-art in language modeling, and you will hear more about that soon if you follow our lab. But what we see is that we were able to make biological sense of our data as well, so these were explainable models. Next slide, please. This was already published in Frontiers in Genetics. Next slide, please. We wrote an editorial about it in the Hindu. Next slide, please. And now we are actually extending our frameworks to infectious disease preparedness beyond COVID-19. Now, we believe that what we built for COVID-19 is applicable to things like antibiotic resistance, to things like what new viruses are going to emerge. We have seen the emergence of so many new viruses in the last 10 years. So can we actually track some of these with our models? Next slide, please. I'll be quick in this so that basically we can end in time. So I'll also talk about a little bit about how we employed AI for building social interventions for COVID-19. Next slide, please. This is called WASH Karo. This project actually started before COVID-19. WASH is water, sanitation, hygiene. Karo is do in Hindi. So it was a mix of do, wash, and the motivation was to provide the right information to the right people in the right format at the right time. Meaning that WASH information is not available to the people to whom it matters the most. Doctors don't read WHO reports, let alone common people, and people who don't know English, they cannot even make sense of those, right? So the idea was to actually build something for those who may not be having all the knowledge and then still get some information about water, sanitation, hygiene practices. This project came out of our sepsis project that was based at AIIMS, New Delhi. But when COVID struck India, we repurposed our backend engine to COVID-19 to provide information. Next slide, please. The WASH Karo engine actually used language models to look at WHO vetted guidelines and Ministry of Health and Family Welfare guidelines, matched them with what news was saying. And if you rewind back in March of 2020, nobody had a clue what to do. And that our paper was actually published within the first 15 days of COVID coming to India. And we basically combined these two different sources and asked the question, can language models be trained to capture what is the right information and what is wrong information and misinformation? I'll not go to details, but these were vetted by human experts. The matched articles were translated into Hindi, summarized, provided in the form of an Android app called WASH Karo, and then users could give them thumbs up or thumbs down, whether that information was useful or not. Next slide, please. And we saw that we were online with our WASH Karo app for COVID for 3 months. After that, the government's policies changed, which then did not allow any COVID information to be spread. But within the first 3 months, we had 11,000 users. And we saw that as people were giving thumbs up and thumbs down, our algorithm accuracy kept going up and up. The green line with the relevant count kept going up. This, we believe, was the world's first AI intervention for COVID-19 in the real world setting, where What people, if you say this is good information, our algorithm was learning some things on the go. So I'll be, yeah.
Dr.
So
Sethi, we are running a little bit out of schedule.
yes, so I'll be quick.
If you could sum up quickly, that would be
I'll sum
nice.
up in the next 2 minutes. Next slide, please. Published, next slide, please. I'll skip this, where we learned how to actually understand the social media messages and then to basically devise algorithms. Next slide, please. Next slide, please. We'll skip this. We'll come to, skip this, please. Skip this as well. So this is where we mine evidence which is emerging to provide it to clinicians. And we were able to actually capture early evidence about thrombosis, even before people started talking about blood clots and COVID-19 vaccines. In August of 2020, we already had evidence on the bottom right about thromboembolic complications of COVID-19 that may be emerging. Next slide, please. Next slide. This is where we built algorithms for resource allocation for COVID-19. We said, can we learn how to allocate vaccines across different states of India? Next slide. And I'll not spend time, but we showed that if we used AI, we would actually always have a higher number of cases prevented than a standard approach that was being taken. Next slide, please. We used deep learning for this. Next slide. The dashboard was publicly available. So I think I'm missing one component here, which was our Safe ICU deployment at All India Institute of Medical Sciences, New Delhi, where we built AI for the ICUs. And we deployed AI for models for shock and antimicrobial resistance. Some of these dashboards are running live at AIIMS New Delhi. We are now working with ICMR to make these data sandboxes publicly available so that public can use, the world can use it, and these will be large data sets, all with the privacy concerns addressed. So as a recap, next slide, please. As a recap, I'll just say that AI is creating new knowledge, is pushing the frontiers. We need to combine different sources of data together, including social media, genomic, and clinical data, to build interventions that are contextual, and then end-to-end deployments are important. Most importantly, we need sandboxes where data and models can come together and innovations can happen. Next slide. I'll skip this. This is our support, our collaborations across the industry, government, and foundations. Next slide, please. I'll stop here and would like to acknowledge my team as well as our supporters and funders. Thank you.